All right, perfect. So it's a huge honor to give the lecture on anatomic shoulder arthroplasty because I think it's considered by many to be kind of the core of shoulder and elbow. So I'm going to try and do it justice. This is a picture of the original shoulder arthroplasty, at least in the modern era. This is Neer's prosthesis. The general concept behind this prosthesis was that it came in 3 sizes. It was a monoblock, so the head and the stem were all one piece. It had no offset, so the head and the stem were all kind of in line with each other. Originally it was developed with no glenoid component, and then later iterations included a glenoid component. And the component was originally made out of vitalium, which is a substance we really no longer use in arthroplasty, but actually I think worked reasonably well. It was pretty expensive. Originally it was developed for proximal humerus fractures. So the idea behind it was that for an irreparable proximal humerus fracture, you would do this, and it was only later that Neer began to do it for glenohumeral osteoarthritis. Okay, we've come a long way, and I want to go through some of the basic design changes that have occurred, because each of them have occurred so as to better replicate the anatomy. And then there's been actually, in some ways, some steps back from that in the more modern era. Okay, so the first change to be made to go from kind of first generation to second generation was to divorce the head and the stem apart. The benefit of this is that then you can mix and match sizes of the head with sizes of the stem. So if you have a patient with a particularly patulous diaphyseal canal, you could put a bigger stem in a smaller head. I'll be honest with you that this is great, but for the most part, patients with big stems tend to have big heads. And so this is maybe not, like, this is helpful, but it's not as critical as you might think. It introduces this junction, the head-neck junction, which is usually a Morris taper. We have not, as thus far, witnessed issues with trunionosis like they've seen in the hip, but this is one potential source of failure. I've never seen a trunnion break. Have you guys ever seen dissociation of the head in an anatomic arthroplasty or trunionosis that you're aware of? I've never seen it.
I've seen actually a head separated from a stem, but I think the reason it was never seen it.
So that's a potential issue, is that you have to seat the head correctly. Okay, so originally this was with the head centered, and this brings me to the first anatomical concept you must understand, which is that there is an offset of the head relative to the stem. So if you look at the center of the diaphyseal canal, which is the black dot there, that is not in the same position as the center of rotation of the head, which is the red dot. What I'm trying to say here is that there is a posterior and medial offset of the center of the head relative to the center of the diaphyseal canal. And this is pictures from, I actually made this picture using Horos, but it's basically overlaid CT slices, and you can see that they're not centered. So this leads us to the offset head. And this is most heads that are used today in stemmed components. The center of the head is not the same as the center of the trunnion. And then you're supposed to use that to adjust to make it right. Now, in the vast majority of the time, you'll be placing the center posterior and medially offset relative to the trunnion, so that the 12 o'clock is going to go at about 8 o'clock on the head, if that makes sense. Okay, so the thing that's nice about this is it allows you to fix it. So if you put your stem a little bit low, then you can use the offset to get the head in the right place relative to where your cut surface is. So like this is an example where like I put in the stem and I looked at it and I was like, God, it's a little bit low. That was kind of where it wanted to sit relative to the calcar. You can then fix it with the offset of the head. Okay.
One thing about that is that that's based upon using a diapsil fit actually reconstruct approximately.
Right.
So a lot of our.
I'm getting to that.
Okay, cool. I just wanted to make sure that when you said they're supposed to be percent, these guys seem to operate.
I'm getting to that. We're going stepwise here. Okay. So historically, people have taken this one step further to say maybe we need varying thicknesses of the head, right? You probably see these most frequently within the striker sets is what are called the soft tissue balancing heads. Even most stemmed arthroplasties still contain multiple head thicknesses for the same diameter. But historically, people have used this to try and fix what is just a malpositioned component. So like this is a very thin head in an old Coalfield component where you see that like the stem is just not down because the stem is too big. And they've used this thin head to try and fix it, which doesn't really fix it. And the reason why this is problematic is because the shoulder is enveloped by the rotator cuff. And this is the main reason why restoration of the center of rotation is important in anatomic arthroplasty. So I will say this is a subject of some debate, but there is reasonable consensus or agreement that within anatomic arthroplasty, getting the center of rotation in the right spot is important for preservation of the rotator cuff later down the road and prevention of loosening of the glenoid component. So that leads me to this point, which is to say that getting the arthroplasty in the right place has become basically the major focus of a large deal of innovation that occurred over the last 20 years in arthroplasty. So here are some of the innovations that have occurred to accomplish that. One of the innovations is to have variability in the neck shaft angle. So this is an Arthrex component called the Apex that I used to use. What you can see is that this stuff through here is a way whereby the component itself can flex. So when you place the stem, it allows you to place the arthroplasty in exactly in line to your cut surface. As you can see, this component is problematic because it then comes loose because it has no ingrowth surface because it was just grit blasted. This leads me in general to short stems, which have been kind of before stemless our major story. And the problem, of course, is it's hard to get the right, with a short stem, it's hard to get the right fit between too big. I mean, this stem is obviously more damaging to the bone than just a well-placed apicil component, or too small and subsequent loosening. So this leads me to probably the most important revelation in anatomic arthroplasty of the past 15 years, which is the stemless component. The beauty of the stemless component is that it overcomes a lot of what I just talked about, right? With the stemless component, you no longer are worried about where the canal is, so you no longer have to worry about offset because there is no offset. The offset is just you're placing the component relative to your cut surface. So this is one version of it. You know, there are many versions of it. Most of them look somewhat like this because all of them are trying to build upon the IDE that Stryker initially did for the simplicity. But this is the base. That's the basic idea. Does that get to what you're trying to say, Bob?
Kind of, yeah. It's more with regards to, so when we're trialing heads and we say, okay, the final position that the head is going to be in is at the offset's going to be at the 11 o'clock position, or the 9 o'clock position, or the 8 o'clock position. If we were using the standard stem-based implant system, the offset would always be posterior, which would be, depending upon if you have a right or a left shoulder, it would be in the 3 or 9 o'clock position that the head would be dialed into. In what we do in the operating room, you see it's everywhere. It's like 9, it's 10, 2, 3, etc. And it doesn't mean that the anatomy of the humerus is changing. It just means that the position that we're placing the implant in is based upon metabosis, not the diaphysis. And therefore, because of that, we're not guided by the relationship of the humerus to the stem, to the canal. We're basically just guided by the relationship of where we position the implant in the metabosis. And there may be slight posterior, superior, anterior offset, and that's what this dial of what we're doing. So when you read textbooks or whatever, they say, okay, there's supposed to be an offset. You talk to someone that's used a stem-based system for years and years, it's always going to dial that into a posterior position. Well, why don't we do that in the operating treating it because we're not using diaphyseal systems, we're using metaphyseal systems. That was basically what
which I think is an important an important thing to piggyback on that is that if you look at the evolution of the stem over time, historically we used diaphyseal fixated components, which is to say that the stem fixates in the diaphysis, and the problem with that, as you know, is you get stress shielding and you lose the proximal humerus. Then if you have to come back, it's a disaster. We've moved over time to more metaphyseal fixation, and that's there are long stems that have diaphyseal fixation. The length of the stem does not matter for where the fixation is. It matters more, where is your ingrowth surface? How is the stem designed? And then we've moved towards this stemless concept, which is hopefully more of a epiphyseal metaphyseal fixation. The general concept is to move the fixation as close as possible to the top of the humerus to avoid stress shielding. I'll be honest with you that has not perfectly played out with stemless components. If you really critically evaluate the literature, it is not clear that there is less stress shielding with stemless components than there was with well-placed metaphyseal short stem or long stem components.
I would agree. And partly it has to do with design. So if you look at, say, a standard diaphyseal stem, typically if there's going to be stress shielding, it's usually approximately 2 to 3 centimeters before there's where the starts to occur. The flex, for instance, is another diaphyseal fixation system. So it's basically where you see that flare occurring. It sort of reduces the amount of stress shielding, probably a 7 or 7.5. Stemless, there is still the possibility of stress shielding. It just is based upon where the bone is located. So there are systems where, like the Arthroplasty system, where the coverage of the plate proximally, it covers the entire cut surface of the proximal humerus. In that system, there's almost no stress shielding. So if you look at like Haber-Meyer series with regards to the Arthroplasty system, there's almost zero stress shielding. Whereas the simplicity, one of the issues with the simplicity is when you use it, you see that the proximal aspect of the implant is slightly smaller than the cut surface. And because of that, you can see, not a lot, but you can see stress shielding back to the area where the metal is. If you look critically at when we did our study on simplicity, so in 2 years, you can see that there's some stress shielding back to the plate of where the head attaches to the implant. It's not where the bone is, meaning the head, even though the head covers the proximal humerus, it's where the metal is being grown into the bone. It's not necessarily where the bone is loaded by the head. That makes sense. Otherwise, all diaphyseal stems would have no stress shielding. So I would agree. You would see that in the stemless, there's some stress shielding.
Okay, so this leads me where we are right now, which is that we have basically two concepts in anatomic arthroplasty. This is one of them, and the idea behind this is that it's an easily revisable component, right? So there's, as of right now, there's no FDA cleared stemless anatomic arthroplasty. There will be probably in the future, and I'm gonna have to change this talk when that happens, but right now that's not, you can't do that as an FDA on-label device. So this is one concept, is that if you do this, and then if you need to revise in the future, the thought is that you will revise it by taking the whole thing out and just putting in a stemmed reverse. Or the other concept is you put in a stem to begin with, and it's a platform component. And what a platform stem means is that you can take off the head and place a new reverse tray. So this is an example of biomets. There's an important caveat to this that you must know, which is that this component is an onlay component. To make that platform stem, you must make a compromise that either you have an onlay component or you have a stem that fixates lower down. So this is I think this is the Integra component. The basic idea behind this stem is that it's fixated here. And then if you want to change to reverse, you would actually take this part out. The problem is that this is a very difficult to revise stem because now it's diaphyseally fixated and it stress shields. So like to go to this stem, we go back in time to all the problems we have with diaphyseal stems a long time ago. So it's just critically understand that that's that compromise when it comes to platform stems. And then the newest innovation in anatomic arthroplasty is this pyrocarbon head. This has been just recently released. I will say that the early results from Australia and Europe look very good with this, and I think we're all excited about it, but time will tell. Thus far, it's a hemiarthroplasty and not an anatomic arthroplasty. There's, as far as I know, no evidence that this is better on poly than metal is. Okay, so that's the humeral component. On the Glennon component, there's also a lot of variations that have occurred, and it's a little bit less clean on the Glennon component side in terms of like generations of improvement. I will say that these are I'm just going to categorize the variations into a couple of different big groups. Big group number one is the shape of the component. So historically, our Glennon components have looked roughly like ovals, and this is, I'm sure, the striking component you've seen with Bob. The other two variations on that, there's this biomet that's a little bit more kind of rectangular and provides maybe slightly greater coverage. And then there's this enhanced component and the shoulder innovations components that are circular. And the idea behind those is that they hopefully get more of an inlay kind of concept, but they don't provide as good of coverage. I will say right now, I do not think that we have any evidence to suggest which of these is better or worse. These are just different variations right now that are on the market. There's also your fixation on the backside of the component. So most of the components we use are all polyethylene, and there is keeled components historically and then pegged components. I think that overall the literature suggests that pegs are better than keels, but there continues to be debate even about that, and there are surgeons who will say that keels are just as good as pegs. On the peg side, there's a couple of different designs. There's 2 pegs, there's 3 pegs, there's 4 pegs. I am not confident that there's a lot of evidence that 4 pegs is better than 3 pegs. Then there is this anchor style component, which you can see on the top right. And the idea behind that was that bone would ingrow into the flanges of that central peg. The overall literature suggests with that if it ingrows, that those patients have probably lower loosening rates, but there's probably 30% of patients in whom it doesn't ingrow, and then you end up with like a cyst around that central thing. So what I've personally been doing with that is I'm cementing that central post, and I'm not trying to let it ingrow because I worry too much about that 30%, because I have patients in that group where I look at their x-rays and I don't like them. What are you guys doing with that anchor peg? Are you still bone grafting it, or are you cementing it? So I think that it sounds like pretty much all of us have gone away from the thought that the bone can ingrow into those flanges. And then there is this concept of a metal component on the backside, and the idea is that bone can ingrow into metal. So the one that's shown on the bottom right is the Regenerex post, which is a biomet innovation. On the bottom left, that's the TM component. I will tell you that these components don't look super different, but the one on the bottom right has a pretty good track record, and the one on the bottom left has a very terrible track record. So there's kind of a fine line here in between how much metal is the right amount of metal, just to be honest. I think that the general consensus right now is that overall metal, like fully metal backed components in anatomic arthroplasty, have a very bad track record. It's unclear in the future if that's going to change. There continue to be people innovating around that with a thought that if you could fix that problem, that you could fix our problems with glenoid loosening. But I think that remains to be seen. When I was in Milan, they presented to me their 10-year follow-up on Lima's metal-backed component, and Lima's component is particularly interesting because it's a fully convertible component. So the idea was you could take off the poly and put on a glenosphere. And they presented to us 10-year follow-up in which 75% of them had failed. And of the ones that had failed, half of them, the glenoid was so destroyed that it was no longer reconstructible, and they converted them to hemis. They had a minority, like 2 of them, that they could convert. In many of the ones where they had to convert them, the metal back was so damaged they could not convert it. And in some of those, the ones that were reconstructible, they could not remove it, or by the time they removed it, there was solo glenoid remaining. It was not reconstructible. So I would caution you about innovations in metal back components. It can lead to a very disastrous situation. Certainly, having removed this myself, it's awful. I'm sure that my partners would agree, and having removed other metal-backed infected components, you're often left with very little. And usually in those situations, either the poly's all gone, or the poly's dissociated, or the poly's cracked, or anyway. So it may be in the future that that's a winner, but for right now, I would say that it's definitely in the dustbin. Thoughts? Agreement? Disagreement?
No, I'm curious to hear what your thoughts are on hybrid, like the new, Zactec or the.
That's what I'm doing. So yeah, I mean,
Yeah.
I think hybrid makes a lot of sense. I just think it can't have a full metal plate. You know what I mean? It has to have poly between the posts to allow flexibility.
You don't cement at all.
For those, I'm bone grafting inside of each of the posts. Yeah.
Because I mean, the true hybrid is like part of its metal and growth and part of it's cemented, right?
Right.
So the idea with like that Zimmer one on the bottom right is you get immediate fixation with the cement and the peripheral pegs, and then it will ingrow over the next 8 to 12 weeks. But
right.
The component that you use, you don't cement at all.
No, this fixation at time zero, I think is so good that I don't think it needs cement. I could be wrong. That's what I think.
I think it's cool.
Okay, so other variations. Another variation is what the backside looks like. So very historically, the components were flat on their backside, and then more recently, almost basically, like I said, I shouldn't say almost all. I think at this point, basically all of the components are curved on their backside. The nice thing about this is, within Stryker system, there's these variable curvatures. The idea behind that is that there is variation in the curvature of the glenoid, and this allows you to do the least reaming possible. It's a little bit unclear whether that variable curvature actually improves outcomes. Most systems, I think, don't have variable curvature. And then there's this biomech component that has this kind of grid on the backside, which I think is interesting. It's meant to be cemented over the entirety of its face. And I've never loved that. What are you guys' thoughts on that? I don't quite understand it.
Yeah, I think two. One is the backside component curvature, or I think Stryker's globally. So
yeah.
The next iteration of basically each size is going to have a single backside radius because
right.
It's based upon when you look at most surgeons doing implants, they choose one. And the one that they typically choose is the flattest curvature. So the reason why flat backs are so good is because they remove the least amount of bone. So if you look at a typical, say you're trying to correct a V2 deformity, the easiest way to correct a V2 deformity is using a flat instead of a curved back. You can figure it. It's like, okay, well, you're gonna ream down the hump. You know what I mean? Whereas if you use a curved back, not only are you going to ream down the hump, you're going to ream down the middle of the glenoid. So from a theoretical standpoint, the reason why they created this was based upon anatomical studies of what the curvature of the glenoid is. But the reality of putting an implant in is that most people want to preserve some combo bone, so that is the flattest implant. Now, you're right, flat backs have, if you look, not a pure flat back, have worse clinical outcomes than a curved back implant. So it's not like no curvature is the best, and probably that has to do with it. Well, foreseeing the flats in the path of a pure flat back implant is just harder to fully see than a curved back implant. But it's like you need the middle ground. You don't want a really curve, but you don't want a perfectly flat. So, anyways, that I think is going away. The grid, what do I think that's from? That comes from Christian Berger. So that's the Zimmer environment, etc. And Berger has clinical data, has animal data, I think it's animal data, or feedback. It's not where he cements the backside. So the idea is cementing not only the post, but cementing the backside of it at the same time. And that was found to have the least amount of micromotion of an implant as opposed to not have a problem that most people have is that it then cracks and then it can peel out and then you have a big, huge gap between the implant and the back. But like when I did my fellowship with Ken would cement the entire backside of the based upon Christian faith.
So he stopped doing that by the time I was fellow there.
Yeah. So I would say that every fellow was cemented the backside. So we did our fellowship, we cemented the pegs, we put a big wad of cement on the backside of the
Yeah.
And then the first shoulder that we did, we only cemented the pegs. And that's not a single fellow. But that is the idea, is that it's going to increase the interface between cement and backside.
Okay, then the next aspect of the variation is these augments. These come in 3 specific flavors. The first is this step, which is shown in the bottom right. This is a DePuy component. The idea behind the step was not that it best matches the bone. The idea was that this right angle step provides the best stability, and that the wedge provides greater ability for it to move. This biomechanically, I think, is like a very sound concept. And the problem is that prepping that step, like prepping the bone to create that step, is very, very challenging, and the instrumentation they provided for it was not very good. So this component was never really all that widely utilized. I've never put it in, despite having worked with DePuy for a long time, because the instrumentation is so bad to put it in. But the 5-year data on this component is actually pretty good for the people who did put it in. Okay, the other the most widely used is this wedge, which is shown on the top right. That's available now, I think, through Zimmer and through Stryker. And did you have wedges now?
Yeah.
Do they have half wedges like this?
Half wedges and no.
Okay. So there's multiple companies now producing these half wedges.
Yeah, the full wedge is like out. It's supposed to be available.
The full wedge, the half wedge, I think, is probably the winner in terms of what people use the most. It's the most bone conserving. It's the easiest to prepare the bone for. It's, to be honest, the only one I've ever used. And I think for the right patient, it can fit pretty well. We don't have long-term data on full wedges or on half wedges. So there is no 10-year data on that component. It's really unclear how that's going to look. The 5-year data thus far looks good. And then the full wedge, which is shown on the bottom here, the idea here is that this is to help you kind of correct for, simple retroversion. This is not for correcting a B2 deformity. It's unless you're, reaming a lot in the middle. It's more supposed to be correcting for retroversion generally. So that's Exactech's version. DJO has a version. I don't think Stryker makes a full wedge.
No, and the discussion actually was, should there be a full wedge and a half wedge now? And back and forth. But, the part where it gets down to SKUs, we have so many boxes that are available and so many options. The upside of the wedge is that it simplifies the instrumentation. That you can use the same reamer that you potentially use for reverse, Exactly. Use for an anatomic. So you correct, to the extent you don't have to adjust, whereas you have to completely adjust the technique of how you prepare for one from an instrumentation standpoint. So it simplifies it. Surgeons will get shoulders. A half wedge is much more innovative than a full wedge because of the simplicity of the downside of it is you can only correct so much.
Right.
So you're going to definitely more on a full wedge than a half wedge, and that's the probably 10 years ago that we're comparing the two. So if you're going to think about the half wedge is better. The other is what's the correctability, and we know that they quote the full wedges, the biggest full wedge are exactly off the market, which I think was a 60.
I never placed that one.
Yeah, and so that was no longer. That was from rights data where they showed high failure rates. So I don't know. I was intrigued by it. But it was interesting. We also said, okay, what's probably the best case to use a full wedge? It's probably B. That's probably what we use it the most. So B2, like you said, you're probably going to straightly looked up, okay, how many B3s were done using anatomic shoulder list in their history. And it was like 10,000 replacements that were graded. I think it was like something.
Right.
So in general, maybe, or it's because they all have reverses.
Well, and that's, you're not going to reverse that trend.
And it could have been that they didn't have, that was the reason that shift over. But the thought was, well, the people are going to be going for short list. So using short list pad or there's already probably a reasonable solution. And you could say that about the halfway teams. Like the other part of that is that, Eric's data and support makes it correlate with, so there is a clinical data that suggests that it has less problem to do with correction and version. It has to do with utilization. I mean, like the patients that did poorly in the study were severe utilization of B3s and B3s probably as most corrected. So I don't know. I was up for it, honestly, when we made the decision. But then the people coming back and said, okay, you guys can choose one half wedge or full wedge.
So I've never used this exact tech full wedge because every time I put it in the planning software, I convince myself to do a reverse.
That's interesting. So
Yeah.
what would be super interesting is looking at the exact database to see exactly that issue of B3s with a system that offers full wedge. What is the decision versus that database to see that almost over 95% of the time I mean, they're going to say
So I don't think they sell very many of these, whereas the augmented base plates, I think is like their best product. Yeah. So the general way that the operation is done is in the beach chair position through a delta pectoral approach between the deltoid and the pectoralis, and taking, I think most of us are taking the cephalic vein laterally, and that gets you down to the clavipectoral fascia. There's a quote from Henry, like of the Henry approach, that I've always liked, which is that the deltoid, if retracted laterally, may offer a begrudging view of the glenohumeral joint, but that may indeed be the last useful thing that it does. So obviously the number one concern with this approach is the axillary nerve, and the deltoid is always in your way. So the general idea there is that you get your exposure of the proximal humerus and then do what you'd like with the subscapularis, which I'm sure we can talk about in another talk, but continues to be a major source of debate. Remove your osteophytes and then do your head cut. And I wanted to this is research that we've done here. So I think if you're planning a stemless, you should still use a guide. So we published this paper in JSCS comparing Bob's head cuts that were done using a guide to Gillespie's head cuts that were done without a guide, and showing that you're more likely to get an anatomic restoration of center rotation if you use a guide. And this is an example. I mean, so this is the head cut that's marked out, by Gillespie. This is what it looks like once you put the guide on, and you can see there is some slight variation between what is planned with the guide and what is planned freehand. I think this matters less if you're using a stemmed component because the stem guides things. So I often tell people, people think a stemless is easier. A stemless, I think, is actually a harder arthroplasty because it offers you fewer guides, and it's easier to malposition the component with a stemless component than it is with a stemmed component. This is true generally with the advancement of technology, that as we have more technology, it usually requires more vigilance on the user to make sure things are working properly instead of less. So anyway, so you make your head cut, and then, as I mentioned earlier, you have to make sure you know where the axillary nerve is, because generally people will do some sort of capsular release. There's debate as to whether you should do a capsulectomy or a capsulotomy, and I don't think it matters, but you can do either of them. But people generally agree that doing one of the two is an important aspect of this operation. And then you get your exposure to the glenoid. And exposure to the glenoid is basically like the center of the operation. It's what the shoulder surgeons think separates them from everyone else, is that they're capable of exposing the glenoid and no one else can do it. I'm going to show you a couple of different ways to do it, a couple of different variations on retractor placement. This is the retractor placement that we would generally use in my fellowship. We would use 3 Bankart retractors, 1 anterior, posterior superior, posterior inferior. Is this still the arrangement you're using, Bob, or are you using a different posterior inferior retractor? This works very well. I think what's nice about it is these Bankart retractors are widely available, this is a pretty good way of doing it. This is the way Romeo did it when I was a resident. He would use 2 Bankarts, 1 anterior, 1 inferior, and then he would put a Dara posterior inferiorly. So there's no posterior superior retractor. The thing that's nice about this is the Dara is much stiffer, so it posterior inferiorly provides a pretty reliable view. The problem with it is that because it's stiffer, it pulls much harder on the humerus and much harder on the axillary nerve. These were Pascal's retractors. This is what you can do if you have a lot of assistance. You can put 5 retractors in. That's a Bankart posterior superiorly. Those are 2 Bankarts anteriorly. That's a PCL retractor, which is a knee retractor that's inferiorly, which is actually basically the same as the Playboy retractor that you'll often see. And you can see for him, it's kind of clipped onto the arm. And then that posterior inferior retractor is a custom that I don't think that's a Stryker retractor. This was Joe Abood's retractors at Rothman. It's just 2 retractors. It's that same Dara that Romeo used posteriorly and 1 anterior. This is nice if you have minimal assistance. Also puts a lot of pressure on the nerve. I didn't love this. As you can see, it's not a great exposure, but I think this works pretty well. This was Greg Nicholson's retractors at Rush. He similarly had 2 Bankarts, and then he would put in this Holman over the top that he called the sunroof. That Holman, I think, is a pretty reliable way over the top. The problem with it that I had was that it's a little bit harder to hold ergonomically because it doesn't have the same bend that the Bankart has. So those are the variations that I've seen. The only other variation, I'm currently using that double bend Holman that I'm sure you guys have seen posterior inferiorly. I don't have a good picture of that yet, but thoughts on this?
So yeah, no, sometimes it's only like this, and so sometimes that superior retractor gets exposed to superior Bankart. So there, I probably say 5% of the time. Exposure to see I don't love the long part of the superscapular nerve. So that's the involved with that retractor. And usually the retractors, they're short teeth are just, it's probably 3 around the edge of the line. This is probably a 7-meter long that goes basically right where the superscapular nerve is. Probably doesn't matter with burgers, but this will probably drill the screws into that nerve anyways, and which is true. I'm
trying not to, but I hear you.
Happens, and I think it's interesting. This semester actually was not discovered where maybe EMG is pretty superscapular nerve. Changes, so probably seeing us and we're not seeing it. Not having except in that rare case where someone has something obviously in the common shoulder placement, superscapular nerve probably isn't much more. So that's the only reason I don't. The other thing that I will say about the exposure part is that you guys will see it when I do, is that part of what we were releasing when we're doing retractors is that we're trying to get the cup moved backwards. So that's the whole idea, is that the supraspinatus and the infraspinatus has, it's not just the humerus, but the rotator cuff has to go backwards with the humerus. And typically the rotator cuff is attached to the vocal. And so it doesn't really matter where your retractors are, but if you are not able to actually push the humerus backwards, then your exposure is going to work. And I think Peter will probably work from exposure. But what I do, which is maybe different, is I spend extra time on the supraspinatus around the base of the forefoot. So I will use the ligament. I'll make sure on the top and bottom of the forefoot I get free exposure. The supraspinatus can push backwards posteriorly, almost a couple pair. And then I'll release the undersurface of the anterior cup, supraspinatus between the labrum prior to placing my retractors. And the reason is because what I don't want to do is put my retractors. A, it will help with their exposure a lot. B is that if it's still tethered peripherally, you're going to actually put a lot of stress on your nerve that you're going to cause stress and erosion. Those retractors will be just like you see the delta get smushed with the retractors. Your rotator cuff will get smushed with the retractors too. And I've seen muscle injuries accelerating in my own patients in the muscle with supraspinatus. Probably that happens in a lot of surgeons. It just goes to the they don't look at it in the case, but something to be observed of. So, anyways, I think that's a good thing for looking at the lab. Down to the lab, and I can show you guys exactly what we do on the base of the
We'll kind of skip to the end here, but generally these patients do pretty well. These are my own data, and then another 3 studies that I've been involved in publication with. Generally, this provides you with a B+ to A- shoulder. 90% of patients are improved by it. And the symptom improvement occurs pretty early. This is data from 700 patients, PRO data from the U of U, that shows that by 1 year, about 91% of patients are improved. And the problem is in the long term that oftentimes the rotator cuff tears and the glenoid comes loose. The other problem with it you should be aware of is subscap failure, which is a problem whether you use sutures or wires or whatever you do, the subscap can fail. And if it does fail, then the patients do relatively poorly. And that's the slide I have here. This is from a recent paper that Levy published, again, showing that the results are definitely worse if the subscap fails. So you got to be cautious because your patients won't always listen to you, and things can go wrong. So that's we should get to conference, but that's the basics. Which one? This one?
So that was that in John's study of where so that's in the press. So
yeah.
That's not been published yet.
Right.
Because he has an osteotomy that it was published that showed his certain incidents of osteotomy failure, and even in the patients that had partial healing of their osteotomy, they still
This is a follow-up of that.
So
it's a second publication with a larger group of patients.
And in this study, was it the difference was between complete failure or the ones that had like a partial one? Where did those fall? Did they fall with the ones that had complete healing or the ones that had?
I think he defined it clinically, not based on X-rays, which is somewhat problematic, but we should get to conference. I don't want to keep you guys late.
Yeah.